proceeding on the rural theme. Invite Scott Weeks to talk about augmenting the rural surgical work.
Good afternoon. Thank you all, thank Dr. Dillon and the International College of Surgeons for the privilege of the podium today to discuss our ongoing projects here at Creighton University. I have no disclosures and these are my objectives. So I would like to start by grounding this presentation as a topic that has real world implications. The type of topic that the whole community feels, not just individual patients necessarily. This is Sacred Heart Hospital. Shortly after it opened its doors in 1889. It's where my grandparents were born, my parents after them, my siblings and me after that. It was the oldest business in northern Wisconsin, in my northern Wisconsin community, second only to the paper mill, and it served the community for 135 years. But like many hospitals across rural America, they closed its doors in 2024. The rural surgical workforce is in serious decline, and access to quality surgical care in rural communities is in peril. With few exceptions, states across the nation are experiencing a decline in the number of general surgeons practicing in rural communities. In the last decade, the supply of general surgeons serving rural communities has decreased by around 1% every year. And yet, over the same period, the overall supply of general surgeons, that's rural and urban combined, actually increased by over 3%. So this is not a problem of surgeon supply, this is a problem of surgeon maldistribution in the country. We're training general surgeons, but we're not sending them to rural communities. While the supply of general surgeons practicing in rural communities is in decline, those who remain are significantly older than their urban counterparts, with a significantly higher proportion age 55 to 74 practicing in rural communities. And this older generation of rural surgeons is no longer contemplating retirement, they are actively and rapidly exiting the profession. At the same time, young surgeons entering practice are far more likely to work in urban centers than rural community practices. Furthermore, young surgeons entering practice in 2026 are prepared for a narrower scope than those who entered practice in, say, 1976. So this is not a one-to-one replacement in terms of services offered by the new surgeons. And finally, it's worth emphasizing that those surgeons remaining in rural communities are performing more surgeries on average than their urban counterparts. So this is not a situation in which there's just less surgical care needed in rural communities to explain the workforce decline, but rather we're squeezing more out of the workforce that's already in decline. And this is a critical problem because the departure of surgeons from rural hospitals, more so than physicians from any other specialty, has the strongest correlation with hospital closure in those rural areas in the ensuing years. And after rural hospitals close, the remaining physician workforce also leaves town. This, of course, is happening in an area of the United States which has experienced nearly 200 rural hospital closures in the past 20 years, with an additional 700. That's 1/3 of all rural hospitals at risk of closing their doors. Rural hospitals rely on general surgeons to remain solvent, to keep their doors open, and when rural hospitals close, the community it serves is dramatically destabilized. So, what are we doing at Creighton University to address this workforce crisis? I think it starts with acknowledging that rural surgery is a unique discipline within general surgery, and anything but bread and butter general surgery. It's a specialty of its own, with a unique scope of practice that's not shared by general surgeons in larger urban centers, with different resources and access to multidisciplinary care down the hall. Rural surgeons often have a particular emphasis on endoscopy as well as crossover with obstetric and gynecology care, as well as ENT, vascular, breast, urology, and other subspecialty procedures. And while this type of practice harkens back to good old days, if you will, of general surgeons performing a Whipple on Monday, an enterectomy on Tuesday, and delivering a baby on Wednesday, today's rural surgeons are not practicing old school surgery. They're caring for patients in an era of booming technical advances, including platforms like robotics, and expanding medical breakthroughs to treatments like immunotherapy that's revolutionizing cancer surgery care. At Creighton, we've been exploring strategies to and building relationships with the goal of bringing high-quality surgical care to rural communities. I have had the distinct honor of being invited over the past 2 years to the American College of Surgeons to help instruct the Inclusive Excellence Certificate course at Clinical Congress, where I represented world interests in the DEI agenda at the American College of Surgeons. And last year, Creighton partnered with the American College of Surgeons to host its inaugural Rural Surgery Roundtable breakfast, where we introduced the work to establish rural standards for the Commission on Cancer Accreditation. These relationships have been certainly solidified the importance of placing patients' needs and preferences front and center in everything we do. As an example, the benefits of the robotic platform for minimally invasive surgery are ubiquitous, and the literature is replete with examples of outcomes and improved outcomes with and without the robotic platform and those outcomes that rural patients experience. But I'd like to argue that there's more fundamental prerequisites quality surgical care in rural communities that the robot cannot fix. And this revolves around access. Access to quality care in the community where patients live, and access to higher levels of care when it's appropriate. In 2023, under the leadership of Dr. Rafai and Dr. Shipman, we were able to organize Creighton University's inaugural Equity in Rural Surgery Symposium, where central focus was on just that, access to quality rural surgical care. And much can be said of the takeaways from this symposium, but a linchpin in improving access to surgical care is to bolster its workforce. And this must include efforts to augment the entire continuum of training pathways. This includes recruiting medical students from rural backgrounds who are more likely to return to those rural communities, defining the core tenets of a rural surgical curriculum that reflects the unique practice model, and prepare surgeons for rural practice, and supporting rural surgeons through mentoring, consultation, CME, so the surgeons practicing in rural areas can retain better nutrition. Last month, a great delegation representing Creighton University was able to spend some time at the North American Rural Surgical Society's annual meeting in San Diego. Many of the programs around the country with a special interest in addressing these exact issues are represented at this great surgical society, and I see a few familiar faces here in the crowd today. I've been fortunate to be invited for the past 2 years to speak on different emerging technologies for rural surgeons. And I would like to make just kind of a special plug to anyone here who is interested in rural surgery, that the North American Rural Surgical Society is the premier surgical society representing rural surgeons' interests. Finally, I'd like to close by talking a little bit about Creighton's most recent rural surgery symposium, which was held last spring. Workforce development will require a multi-level approach, but at every level, we must leverage the appropriate leadership and advocacy to enact real, impactful changes. We were extremely fortunate to welcome the president of the ICS at the time, Beth Sutton, to speak to us about our experiences as a surgeon practicing in rural Texas and the work being done at ICS to support the development of the rural surgery workforce. We also welcomed our United States Congressman, Don Bacon, to join us to discuss the national priorities for rural surgery healthcare development. Creighton was able to continue this important effort of workforce development through advocacy at the ICS Leadership and Advocacy Summit last week in DC. And so I'd like to close today by re-emphasizing the importance of the role of rural surgery in supporting rural hospitals and their community. Addressing workforce decline requires that we acknowledge that rural surgery is a unique practice model, and that rural surgeons are required to care for patients in the communities with different resources. It takes many years and phases of education to train a rural surgeon, and each of the steps along the way in this pathway needs to be bolstered to address the workforce crisis in a sustainable way. And this cannot happen without a full understanding and application of advocacy with the appropriate stakeholders. And finally, rural surgical workforce deficits impact everyone in this field. As rural hospitals close, the patients they serve need to find care elsewhere. This often happens at urban centers with more advanced disease requiring more intensive care, and rural patients deserve much better. So I'd like to thank everyone and welcome any questions.
Dr. Weeks, great presentation, and the way you sort of went into connected it to your ancestors.
Thank you.
So, the quality it to the audience, one of the main issues beyond reimbursements, how critical access hospitals were affected over the last 15, 16 years. When we talk to rural practitioners, particularly rural surgeons, is professional isolation. What are your thoughts on that?
Yeah, professional isolation has been cited over and over again as a deterrent for young surgeons entering practice in rural communities and for established surgeons leaving the field. I think that to some degree that is a poor excuse and one that we can do better at mitigating. In 2026 we have access to great technology, Zoom and the rest, and I think we can do better to incorporate rural surgeons in our day-to-day practices at larger academic centers so that they're feeling less professionally isolated in these areas. And I think that would be a great first step in helping these surgeons out.
It's not great job. I really appreciate what you said. So I was rural surgeon for 3 years after graduating, and what we did at UAB was we tried to hire surgeons through the university and put them in the rural community. So that kind of helped with the professional isolation aspect. And I was one of the private surgeons who was put down there, and really I had access to tumor boards, specialty consultations. The one thought, and I just want to hear comments about it, you said, what can residents do for rural surgery? What are your thoughts about involving chief residents more in running rural surgery clinics under supervision of a rural surgeon? And by doing that, we can solve the problem of autonomy, bridging the gap, at least with general surgery cases, and giving more exposure to our residents to culture, hospitals, resources, so maybe they will consider this as a career in the future. Because we talk to our own residents and nearby program, and the biggest problem was professional isolation. The thought that the training wasn't enough to, meet the need. So just wondering what your thoughts are about involving the chief residents more, maybe under a restricted license, and then we can do more in the future. And that may help bridge the gap.
Yeah, I couldn't agree more. I think that the more that we integrate trainees into rural practice, the more comfortable they're going to be going into that type of practice so they can see and understand the challenges that they're going to be faced with and feel prepared to take it on. I think some of the challenges that I've heard several times over is just the challenges in the logistics from an ACG&E level of approving these types of rotations and the rest. And then of course, having some stability at these rural sites such that we can, as a residency program, continue to plan on sending residents out to these locations. If you lose one surgeon at a large academic center, it doesn't disrupt the residency as much as, say, if you lose one resident or one attending at a smaller rural hospital. Now all of a sudden that rotation is completely put to kibosh because of the instability that it causes. I couldn't agree anymore.
So I had a great talk. I had a comment for you. My background is trauma and surgical critical care. So I started my career off at a level 1. At this point in my career, I'm doing some locums and actually cover critical access hospitals and do just general surgery and critical care. Having said that, it's kind of given me a whole different perspective because, again, kind of worked in the academic arena at a level 1 center and now in the critical access arena where, you're right, I cover one hospital where they literally had one surgeon. And so for him to go for CMEs or go on vacation, et cetera, they needed to bring someone in to cover for him. I'm a DO, so kind of a minority in the audience, but I can tell you that historically, one of the things that has happened since single accreditation back in 2018, 2019, thereabouts, when it occurred, was that many osteopathic surgical residency programs were shut down because we didn't meet some of the academic rigor that was required by the ACS. The end point of that was that we know that greater than 60% of residents stay within 100 miles of where they train. And so by closing these programs, we literally eliminated a source of surgeons in these rural communities. Many years later, we're now realizing that, oops, we really do need to focus on some rural surgery access, but we literally eliminated programs, and now we're dealing with trying to recreate programs. Because the training and the requirements of a rural surgeon are vastly different from what, you know, you need as an academic surgeon, you know, in a major setting. I think, I'm just saying, you were saying trying to create a curriculum and what we need. These are great ways where the DOs and the MDs can come together, because we've been doing it. So we reach our 100th anniversary next year. So we've been doing it for a while. And at the ACOS, greater than 60% of our membership is actually community and rural based. So we've got people at Hopkins and Harvard, et cetera, but again, the majority of our surgeons are doing exactly, you know, what you're talking about. So reaching out, creating collaborative programs, I think would be great, because we don't always have to reinvent the wheel. We know that we have a paucity of surgeons in the rural arena, and we know how to fix it. So maybe working together would help.
Thank you for those comments.
Thank you, Dr. It's been a great talk.
I know we need to wrap up, but I just want to make a friendly amendment. The ACGME is fully behind promoting rural rotations. And I can speak now because I rolled up to surgery RC. We've been looking for rural rotations to recruit. If there was ever a rejection, it's because the supervision wasn't right or something wasn't right. But I just want to be sure ACGME is fully for it.
I would agree with that. There's been many advances, both ACGME and the ABS.
Excellent job, Dr. Yates. And I have to give him credit. He's the brains behind our symposium, the first one, second, and humble. I had to revise his presentation to play up all the great work you've done. Next presenter is Dominic Regli, who is a second-year medical student here at Creighton University. Domin's actually from rural California. He's going to talk to us about cutting-edge, meaning country roads, is robotic-assisted surgery right for rural setting. Thank you.
Thank you for having me here today. It's a true honor to speak in front of you. I'm Dominic Regli, I'm a medical student at Creighton University, and today I'm representing the Department of Surgery at Creighton University. I'll be talking about robotic-assisted surgery in the rural setting. I have no financial disclosures, and the objectives of this presentation are to first talk about the current state of robotic-assisted surgery, and then we get to the gap that my mentor and I came across, and the framework we developed to approach this gap, and then ultimately the call to action towards a sustainable future for rural surgery. So as far as the current state of robotics, over the past few decades, robotic-assisted surgery has increased in prevalence. And with that increase in prevalence has come a corresponding decrease in laparoscopic and open approaches. As far as cost and outcomes, robotic-assisted surgery is consistently more expensive than laparoscopic approaches, as we can see in this graph of key general surgery procedures. And in the literature, there's been several publications to say that robotic-assisted surgery is not clinically superior to laparoscopic approaches. And this has led Blue Cross and Blue Shield to say that it is not considered medically necessary. And so robots in the rural surgical space. So about a year ago, my mentor, Dr. Kyle Cassidy, and I had this question of what the current state of robotic-assisted surgery was in the rural setting. And in reviewing the literature, we found that there was very little known about this. And this first led us to write this editorial that was recently published in the American Journal of Surgery, in which we discussed potential benefits and barriers to robotic surgery in this setting. And this was ultimately the launching pad for our research framework. And this research framework started with surveying rural surgeons on their training exposure to robotic surgery during residency and fellowship, their current utilization of robotic-assisted surgery in their rural practice, and then their perceived benefits and barriers of robotic-assisted surgery. And the goal of this was to forward and not just promote technology adoption. And through these survey results, as well as conversations with surgeons at the North American Rural Surgical Society meeting this past February, there were some key benefits that were highlighted to us. One that was highlighted was that the robot can act as a surgical assistant. Oftentimes, these rural surgeons are covering multiple hospitals, and it can be challenging for them to work with different teams at each of those hospitals. But that robot is a consistent assistant for them. There's also a recruitment aspect where many fellows and residents are being trained on the robot, and having a robot in a rural hospital can be very appealing in bringing these new surgeons to such practices. There's also the increased technical ability that comes with robotics and patient retention and community expectations, where a community hospital needing a robot is a great look for that hospital. But there's also been some key barriers that have been well highlighted to us. Of course, there's the cost. A robot is a large investment, but one interesting factor that was brought forward to us was there's infrastructure implications to purchasing and implementing a robot, where many operating rooms aren't even big enough to fit the robot, and for a rural service center, they may have to completely retrofit their operating room, which when you have 1 or 2 operating rooms, this is a huge barrier. There's also workflow challenges where it's been well highlighted that there's staffing issues in rural surgery centers. And when a surgery center acquires a robot, they have to train their staff on utilizing that robot. There's also residency training implications that have been shared with us. One surgeon shared that they have recently hired a new surgeon who just completed residency, but during residency, this surgeon was primarily trained on the robot. But at this rural surgery practice, they didn't have a robot and primarily used laparoscopic approaches. And it was incredibly challenging for this new surgeon to integrate in this primarily laparoscopic practice. There's also closure implications. One surgeon highlighted to us that he inquired about getting a robot for his surgery practice, but had concerns about case volume. He said that oftentimes he'll see 1 cholecystectomy in a month. And he brought this concern to the industry representative, and the industry rep's idea was to have one hospital have a robot in a large geographical area, and for the surrounding hospitals to refer the robotic cases to that one hospital. But we know that surgery centers are oftentimes what keeping these rural surgery or rural hospitals open, and referring these surgery cases could further exacerbate the rural hospital closure crisis that we are currently experiencing. And so moving forward, over the past year, my mentor and I developed this research agenda to uncover this gap in understanding what the current utilization of robotic-assisted surgery in the setting was. And we identified 3 key pillars to start out this research agenda. Currently, we are defining the landscape and assessing the needs through the utilization of our survey, as well as conversations we're having with surgeons. Our next step would be measuring outcomes, looking at how a robot affects surgical quality and patient safety. And these 3 pillars will form 2 frameworks, the first being on rural surgeon advocacy, where rural surgeons, through evidence-based advocacy tools, can determine whether or not a robot is well-suited for their practice. The second framework is around workforce integration, where by understanding the context of these rural surgical practices, then can better inform residency curriculum design to prepare residents to enter into this unique setting. And ultimately, these come together to inform both education and policy outcomes, where we can develop national robotic-assisted surgery competency expectations, while also driving policy that is geared towards sustainable rural surgery practice. And so why is this important to the International College of Surgeons? Well, local surgery and rural surgery parallel each other in several domains, in that they face lower surgical volumes, limited capital and staffing, and a greater dependence on surgeon versatility. And it is our duty to ensure that technology serves patient access and system sustainability, and not just market pressure. And so in conclusion, we know that robotic-assisted surgery is gaining popularity, and there's this gap in understanding in how it is being utilized in the rural space. And our goal is to develop an understanding that is based on the context of these rural surgeons that is ultimately oriented towards more equitable surgery. And while what we're doing is primarily focused on rural Nebraska and the rural United States, what we find here may very well have huge implications for equitable surgery across the globe. With that, I would like to thank the research team, Dr. Albert Fye and Dr. Kyle Castley, for all their guidance and support in our endeavors. And if there are any rural surgeons here today, I'd be more than honored if you'd be willing to snap a picture of our QR code and share your perspectives on robotic-assisted surgery in the rural setting. Thank you so much for your time. It's an honor to be here today, and I'd be happy to take any questions you might have.
Excellent job. To stay on time, we have 2 more presentations. We have time for 1 question for Dominic, and he's going to stick around after the presentation for additional questions.
Thank you. That was a great talk. Quick question. We talked about the cost of the robot, and that's the biggest problem in the community. Do you think it's time we start considering cheaper alternatives, cheaper robots, which are present around the world? They're just taking to one company. What are your thoughts about that? Might be a complicated question.
Definitely. I think, yeah. Because in the literature, it's well highlighted that, with the current price of a robot, you really need a high case volume to make purchasing it make sense. And so I think an alternative, you know, I think somewhere with a lower case volume where it might not make sense for to have one of these newer robots. Yeah, if there's alternatives to more affordable robots, or you know, if we're not necessarily demonstrating clinical superiority, then maybe you know advocating for more laparoscopic approaches.
Other questions from them?
So you kind of mentioned, or others mentioned kind of the challenge of isolation, not having obvious partners nearby. A lot of robotic surgery requires training for prolonged periods of time. So what does that look like in the rural setting when someone goes straight out of practice directly into that rural setting? How would that be managed? Or how have you heard others speak?
As far as just being well prepared to enter into utilizing a robot?
Right, or getting mentored while they're there. I know it's a tough question, but.
Yeah, if I'm understanding your question correctly, this is in our survey, one of the questions we asked them was about that training they had on the robot or not, and then to really, you know, gauge an interest of like how does exposure and residency influence one's utilization or even perception on robotic-assisted surgery. And so we haven't quite had seen a correlated, you know, training and exposure and residency to preference to robotic-assisted surgery. But I think it's a really important question to understand. Yeah, how is exposure going to influence, you know, and for someone who didn't receive training and now they're in this isolated practice, how are they then able to go back and gain the skills necessary in practice? They're all great questions.
I think Kelly Crawford might be one thing.
Thank you very much.
It's so nice to see such young people that he was very interested in all these topics, which, to be honest, when we were training, we had neither had the idea nor the clue. But anyway, the next talk is by Jillian Timperley. She's going to talk about rural cancer surgery and policy research at Creighton University School of Medicine.
Thank you very much for the opportunity to speak today. Today I'll highlight several studies from our Rural Cancer Surgery Research Program at Creighton, focusing on surgical access, outcomes, and the policy environments shaping care for rural patients. Across this work, our goal has been to better understand the factors that influence whether rural patients are able to receive timely surgical cancer care and how policy, social context, and geography may shape those patterns. And this work is supported by the State of Nebraska LD 595 program grant, as well as the Kuwait Foundation for the Advancement of Sciences. So to begin, I think it helps to briefly step back and look at the broader rural health landscape. Rural cancer mortality remains higher than in urban settings, and at the same time, more than 140 rural hospitals have closed or stopped providing inpatient services over the past 2 decades. Workforce shortages, hospital consolidations, and ongoing financial pressures have reduced local surgical capacity in many rural communities. And as a result, rural patients who often already have a significant burden of disease may face longer travel distances, fewer available specialists, and increasingly fragmented systems of care. And together, I think these challenges raise an important question about what is actually driving disparities in rural cancer surgery. Is it insurance coverage? Is it social context? Is it geography? I think one place to begin exploring this question was insurance policy, particularly Medicaid expansion, because it represented a major shift in coverage across many Midwestern states. So in this study, we used state inpatient databases from 2010 through 2022 across 9 Midwestern states. And we examined colorectal cancer surgical utilization, elective surgery rates, inpatient mortality, and length of stay, and stratified that by payer and morality. Insurance coverage increased in expansion states as expected. However, we did not observe sustained improvements in colorectal cancer surgical utilization, including among rural patients. And there was a brief increase shortly after implementation, but again, it was not durable, and elective surgery rates among rural patients remained relatively low. These findings suggest that Medicaid expansion alone has not been sufficient to improve access to colorectal cancer surgery across the Midwest, and the persistence of low elective surgery rates among rural patients may reflect those structural barriers such as hospital closures, workforce shortages, and fragmented referral pathways. And while policy plays an important role, it may not be fully capturing the challenges that rural patients face when accessing surgical care. Another factor that's receiving increased attention is health-related social needs among rural surgical patients. And in this pilot study, across more than 10,000 eligible hospital encounters, about 11% of patients screened positive for at least one social need at admission. Most commonly, it was for food insecurity, transportation barriers, and housing instability. And I think this highlights how non-medical barriers may also be influencing surgical access and outcomes. And so building on these findings, we also examined whether surgical access varies across different regions of rural America. So in this study, we analyzed more than 330,000 hospitalizations of rural patients undergoing colorectal cancer surgery between 2007 and 2020. Elective surgery rates, which can serve as a proxy for access, were highest in the Midwest and lowest in the South. And we also observed regional differences in in-hospital mortality and stoma formation. And these findings highlight that, rural America is not heterogeneous, and that regional infrastructures, provider distributions, and referral networks, may be influencing surgical access and outcomes. So when we step back and look across these studies, I think it becomes clear that no single factor fully explains rural surgical access. And so recognizing that complexity led us to develop a rural surgery research framework. And so this framework adapts the NIH Minority Health and Health Disparities Research Framework and tailors it specifically to rural surgical care. It organizes drivers across 4 levels. So individual factors, interpersonal dynamics, community-level infrastructures, and societal or policy forces. And the goal was to provide a structured way to study how these factors interact and ultimately shape surgical access and outcomes in rural settings. And of course, the framework is only useful if it reflects real-world experience. So we're currently validating and refining it through pilot and provider patient surveys as well as focus groups. And the goal is to ensure that the framework reflects what clinicians and patients experience in practice. And these insights will also inform future curriculum through the American College of Surgeons. And this work is unfolding during a period of significant change in rural healthcare. New federal investments, including the Rural Health Transformation Program, are emerging alongside ongoing financial strain, Medicaid policy shifts, and continued hospital vulnerability. And how these investments will ultimately affect rural surgical care and workforce stability remains uncertain. So I think if there's one takeaway from all this work, it's that rural surgery is multifactorial. Access and outcomes remain uneven and are shaped by interacting influences, including policy, social contexts, and geography. And improving rural surgical access will require recognizing that complexity and developing solutions that operate at multiple levels. And I think that research can help identify where meaningful intervention is possible. And with that, I'll say thank you.
Great presentation. So, quick question. You're focusing on policy, which is fantastic, because policy drives what we do in the trenches. You alluded to the Affordable Care Act. Can you comment a little bit on the trends in the closure of critical access hospitals after the passage of the Affordable Care Act?
I know that there has been some research in this issue, and I think that's an important area. It's something that we have had a hard time addressing. There's, I think, a potential for a connection there, but again, that question is incredibly hard to answer with the data that is available.
This is part of the names and right that we're for. That's
Yes.
the question.
Yeah, stay tuned.
She can't discuss it. Question, yes, sir.
I think a lot of the problem, or some of the problem, at least with rural, is whether it's 5 miles out of town or whether it's, 45 or 50 miles out of town, is marketing. Because a patient will get a diagnosis locally, and all of a sudden they'll decide, I want to go to Florida because that's where the Cleveland Clinic is, or Cleveland, Ohio, or I want to go to Phoenix or some branch of the Mayo Clinic, where they have, 35 people who could address their problem within 20 miles of where they live. Who's going to fix that?
Absolutely. That's such an important question, and I think pushing research again, if they can see a study that shows that outcomes are similar between the hospital near me versus, that, and I think that work is being done, and I think marketing that is important.
Well done, Jillian. Thank you so much. Because it's actually future Dr. Jillian Timperley. Dr. Jillian's applying for medical school, so will be a phenomenal future position. We'll close this session with Dr. Dillon Wade, one of our general surgery residents at Creighton. He is more than halfway through the year for this. He's a research fellow in department of surgery, and he's going to talk to us today about advancing equity in rural surgery with artificial intelligence. Dillon?
Thank you for that wonderful introduction, Dr. Alfai. Hello, everyone. It's an honor to be with you all today and speak on some of the work that we're doing here at Creighton University in Omaha. There are a few funding sources of this work displayed here. Also, I'll be mentioning a few commercial AI tools, and I have no relation or any endorsement of any of these tools or their manufacturers. So, artificial intelligence in surgery is accelerating rapidly. We're seeing computer vision tools for adenoma detection and breast imaging, natural language models that are being used for documentation and patient communication, as well as predictive analytic models that estimate post-operative complications and even map geographic disparities among communities. There's no shortage of this innovation, but despite this explosion in development, adoption among surgeons remains limited and uneven. Implementation science in surgical AI applications is widely underdeveloped. Recent literature has warned that we risk entering this trough of disillusionment if the deployment lags behind the current enthusiasm. We currently lack structured guidance on many of these topics, including workflow integration, stakeholder trust, ethical safeguards, and infrastructure readiness. This gap is magnified then in rural settings where infrastructure, workforce, broadband access, and specialty support are already constrained. So rural surgery does not just have fewer resources, it also faces a host of much different barriers. Yet most AI tools are currently being designed and validated in the urban setting. We've encountered this gap firsthand in some of our area work. So some early lessons in recovery. In this R1, we partnered with Georgetown and MedStar to evaluate AI-assisted remote symptom monitoring after GI cancer surgery. Here we saw an enormous potential, particularly among the rural patients who live far from the tertiary care centers. However, we began to encounter some of the barriers in the rural environment that we didn't fully anticipate or even understand. From there, we had to step back and ask ourselves, what does the rural AI surgery landscape truly look like currently? So to begin with that, we, in our recent AJS article, we then attempted to define this landscape. We began by identifying current AI applications being used in urban surgical care settings. We then proposed where these tools might be adapted to rural care and how they may alleviate some of the rural specific disparities. We also highlighted some of the risks and barriers that we may see, such as trust, governance, and infrastructure gaps. However, at this point, this was purely conceptual. We lacked stakeholder-driven data to be able to support these ideas, and this led us to dive further and seek the data for ourselves. So, supported by the Lynch Cancer Research Center, we then narrowed our focus to specifically fit within our population of GI cancer care. Aim one of this project consists of a mixed methods study seeking to gather rural stakeholders' current uses, perceptions, and possible barriers to AI use in the rural GI cancer care setting. Phase 1 consists of 2 focus groups, one with post-op GI cancer patients, and one with rural stakeholders, including surgeons, medical oncologists, the care teams associated with the surgical care team, administrators, and of those stakeholders who are either working in a rural environment directly or caring for a large rural population. So this data gathered will then inform phase 2 that consists of quantitative surveys among the same defined groups. Survey domains will include perceived barriers, trust, ethical concerns, resource constraints, and willingness to adopt AI tools. From this data gathered, we then plan to develop a stakeholder-informed implementation framework for rural AI use in GI cancer care. This will function as a checklist to guide AI development in rural settings. We anticipate 3 major domains being readiness, acceptability, and integration. While Aim 1 will ultimately define this framework, our goal is to ensure that before AI tools are deployed in the rural surgical care, that the system is truly ready with a structured implementation framework. So, AI development in surgery is rapidly accelerating, but currently the implementation is lagging behind, especially in these rural communities. Rural surgery equity will not be achieved through the algorithms alone. It requires structured, context-aware deployment, and if rural systems are not involved in designing these implementation strategies, disparities may widen rather than narrow. So I thank all of you for your time and welcome any questions or further discussion. Thank you.
Excellent job, Dr. Wade. Questions for Dr. Wade? Yes.
Sorry.
Thank you. Great presentation. So the framework you described in 2 slides behind, all of those components are equally as important for implementation in high resource settings, right? So did you find something unique to low resource settings only?
So this is currently an ongoing study. So the proposed framework currently will be the domains that we expect to see from other urban settings and from other implementation science strategies. Again, I expect to find, and that's what I hope to find ideally among this study, is to find the things that specifically rural communities are going to be needing prior to coming to administration and saying, I want to be able to implement this AI tool in my care, to be able to have a bit of a guideline and some checklists, things that they need to make sure are there in order for that to be successful.
Great talk. It's fascinating to combine low technology with high technology. That's fantastic. So, as we know, AI goes between hype and reality. Mostly now it's hype that will translate to reality, but until then, the problem with AI is there's no way of verifying what is accurate. So if I ask any of the AI grok or anything about a question about country's cancer, you pose that question 3 times, you get 3 different answers. So how do you plan to correct that or account for that while you proceed with your study?
Yeah, I think, thank you for that comment. I think the wide variability in confidence in different AI tools that will still take quite a bit of time for validation for each tool. And we'll have some tool-specific research that's going to be needed. My goal would really be able to get to a point to be able to have everything together that you may need and that you may encounter. But as far as the variability, that's going to still need a lot of individualized research among each one of those topics.
Do you mind if I interject? I think you asked a very good question. I appreciate your asking it. A couple of thoughts. The R1 builds on an AI chatbot that has been validated in urban settings, especially with research community. And when we went back to the NIH, we decided to have the site also a rural setting, understanding that there was some limitation. The state grant, the third part of it, is actually the grant builds exactly on the question you're asking. So we're going to have a focus group first, stakeholders including patients and rural stakeholders. Take those questions and then present them to patients in the RCTs. It's exactly that the question we're asking. The big question is, will it have an impact or not? Before you go that route, you want to test it. That's what we're doing.
As well as I hope to gather from this, just like you bring up the current trust and perceptions of rural surgeons, I think both surgeons in urban and rural environments kind of hold a unique group of thoughts, and to be able to ascertain the ideas of rural surgeons on their trust and belief in a lot of these systems is important for them.
Wait, do you want to explain to them, I'm thinking, Kay, about the early observation, how you were surprised by the perception of rural versus urban patients towards AI?
Yeah, I think it was a very interesting finding within the R1, within Recover. We actually noticed that the rural patients were overly eager to interact with the system, whereas before this, treating a large Western harassment population, it can be very difficult to treat sometimes, especially during harvest season. We figured that there would be a lot of barriers as far as just education around the system, health literacy, but actually these patients in a rural setting were so eager to communicate and have a better tie to their surgeon that they interacted with the system actually quite a bit more readily than some of our urban patients.
Rifat Latifi from Tucson. Excellent job. I rose up because of your last comment that rural folks wanted more technology versus the other guys. We initially, when we were doing teletrauma and telemedicine in Arizona 20-some years ago, we were concerned that the Indian folks in an Indian reservation is somewhat shy and they would not want to look in a camera and talk to you on a camera and so on. It turned out to be completely wrong. They actually loved it, and they were they were looking at the camera rather than looking somewhere else when you examined them, at least when I did. So I'm not surprised at all, actually. And certainly, but what is, can you just tell me, why are they going to use the AI in surgery for what? Education, dictation, medical records? What's going to be the outcome?
Yeah, so thank you for those comments. So for the setting of this study, the goal is to ascertain overarching ideas, being non-specific, but some specifics that there will be used for both in administration, administrative duties, patient communication, different natural language processors that interact with patients, have a closer tie to a patient who's further away, who may not be able to have as frequent visits. And then again, as I mentioned, a large role in administration, with rural surgeons citing large documentation barriers, different administrative duties that other urban surgeons don't necessarily have. It's one of the largest reasons for burnout. So where I've seen AI as a large potential bolstering of the surgical workforce issues that we see is that it allows a lot of bridging and deliver a large amount of information, a large amount of tools without necessarily having to have the people on ground that we struggle with. So we're exploring if this could possibly be a potential additional solution to the problem.
It was one study that actually people spend more time editing those documents than they wrote themselves first time. So I'm sure we're going to get better. That's an AI going to get better because we are teaching AI as we were given information. But just to keep in mind, it was one study that actually they spent much more time going through the charts and editing words and changing words than if they had dictated themselves.
I think we have a long ways to go.
Thank you, Dr. Wade. This concludes our session. We appreciate all the questions. Let's give a round of applause for all of our presenters. I want to thank my friend and colleague, Dr. Archandra, for co-moderating the session with me. And I'll hand it back over to you.
Yeah, so thank you both, Dr. Ari, for moderating a really great session. Really highlights the best and brightest in Omaha, right? So congratulations, great talks. Three housekeeping notes that I just want to mention. One, Dr. Alviar generously donated 2 paintings that you may have seen displayed there. They're beautifully painted. If you did not paint them,